And the next thing that you want to look for is the presence of free fluid. This is a very, very important finding. Although not specific, it may be the only ultrasound finding in as many as 15% of all ectopic pregnancies. In addition to being a diagnostic finding, it also has management implications because it's a very important clue to helping to assess patient stability. These patients come to the ER often very early nowadays, and so often they are hemodynamically stable, and the referring physicians are therefore have a lower index of suspicion that these patients may have a large amount of hemoperitoneum in their belly, or that they may need surgery. And so very often, by identifying a large amount of hemoperitoneum, you perform a very important service to the patient, because you may be the first physician to realize that the patient, while hemodynamically stable now, in fact has a large hemoperitoneum and is just one step away from being hemodynamically unstable. So again, it is very, very important to look for this free fluid, not just to help you make the diagnosis of ectopic pregnancy, but to assess the patient's hemodynamic stability. A couple of things to remember about this fluid is, number one, it is free. So when the patient walks into the ultrasound suite, the fluid is likely going to be in the cul-de-sac, because that is the most dependent portion of the pelvis. But once the patient lays down on the examining table and they lift their buttocks in order to get into the stirrups of the GYN table, or sometimes they lift their buttocks because you put a few towels underneath in order to help you visualize the pelvis better, the cul-de-sac will no longer be the most dependent portion of the pelvis, and that fluid will move down into the upper abdomen around the liver. So it is very important to not just scan the cul-de-sac, but also to look in the upper abdomen around Morrison's pouch for free fluid. So in this case, you see fluid outlining the liver and between the liver and the kidney. And not only, again, does this help you identify the fluid that you might no longer see in the pelvis, but also helps you quantitate the fluid, because if there's enough fluid that you can see it in the upper abdomen, it usually means there's been a fair amount of bleeding in the pelvis, and that patient may not be stable for long. The other thing is that this fluid is hemoperitoneum, so it is echogenic. It is not bland anechoic fluid. And so it is important to look for clot and echoes within the fluid. Sometimes it's very easy to identify. You can see layering, as you see in this slide on the left. But sometimes when you see internal echoes within the fluid, it may be difficult to determine whether or not these echoes represent true blood particles, or whether or not it represents artifact. So it's important to make sure that your gain settings are correct. If you turn the gain up too high, you can create artifactual echoes in all fluid, but if the gain settings are too low, you can lose the echoes from true particles. So what we recommend that you do is that you start by looking at the bladder. You adjust your gain just so that you start to see some artifactual echoes, then you back off from the gain till the fluid is anechoic, and at that point you know your gain settings are correct and you don't adjust them as you examine the rest of the pelvis. Another thing that you can try and do is to have the patient roll, or to actually poke the fluid with a transducer, and if those particles are real and not artifactual, they will move as you have the patient move or as you poke them with the transducer. Another thing to remember is if there has been a lot of bleeding, or if the bleeding has been very rapid, clot may occur. And when you have clot in the pelvis, the echo texture is very heterogeneous and very similar to bowel. And in fact, it can silhouette with the bowel and can be hard to see. It sometimes can even silhouette with the uterus, so it can be hard to identify the serosal surface of the uterus. So in this patient on the right, you can see that there's a lot of amorphous material in the cul-de-sac, and it looks a lot like bowel. How can you differentiate bowel from clot? Again, clot would be a very worrisome finding. You can turn on it. If it's bowel, it ought to be tubular. You can, again, poke it with a transducer. If it's bowel, it ought to peristalse. But again, I just demonstrate this finding to you because occasionally clot can look a lot like bowel, and clotted blood implies that there's been a relative large amount of rapid bleeding, and again is a worrisome finding in terms of the patient's hemodynamic instability. However, there's some problems with looking with free fluid because it's a non-specific finding. First of all, there are other causes of hemoperitoneum. This is a patient who had undergone assisted reproduction, so her dates were very good. We knew she was only about 3 weeks pregnant, and so therefore, although we could not see any evidence of an intrauterine pregnancy within the endometrial stripe at this early gestational age, that might be a completely normal finding. But she presented because of acute pain, and you can see her ovary here, and you can see a large amount of amorphous clotted blood around this ovary, in the cul-de-sac, some free fluid as well as some clot, and also some clot in the anterior cul-de-sac as well. And when you see this much hemoperitoneum within the belly, this patient was actually hypotensive as well as having severe abdominal pain. And there is no evidence of intrauterine pregnancy. You do need to say you can't exclude an ectopic pregnancy, and this patient went to the operating room. At the operation, they found that all this was bland hemorrhage from a ruptured corpus luteal cyst, and in fact the patient had a very early intrauterine pregnancy that was below the level of our ability to discriminate it on endovaginal imaging. So remember that hemorrhage from a corpus luteal cyst is the most common false positive diagnosis of ectopic pregnancy, and that hemoperitoneum is not a specific finding for ectopic pregnancy. Now, it was not a mistake to send this patient to the operating room, even though we said we couldn't exclude an ectopic pregnancy, because she was hemodynamically unstable and needed the operation in order to stop the bleeding. But again, it is a non-specific finding. Well, what about our accuracy of ultrasound? I've described to you all the things that you would look for in terms of trying to make the diagnosis of ectopic pregnancy on endovaginal and transabdominal imaging. And so the question is, how good are we? And this is a study that was published from the Brigham and Women's Hospital in the early 1990s. This is a meta-analysis of 10 other earlier studies. And when they used as a criteria or criterion for diagnosing ectopic pregnancy as the presence of any non-cystic extra-ovarian adnexal mass, they found that their specificity was very high, close to 99%, but their sensitivity was only about 84%. And what are the reasons for this? Well, one of the primary reasons for this is that we examine patients too early within their gestation before we can identify either an early or an extrauterine, early intra or extrauterine pregnancy. Now, when they looked specifically at the findings that I've just reviewed with you, again, it is the presence of that extrauterine gestational sac containing the yolk sac or the embryo that has the highest positive predictive value for an ectopic pregnancy. However, if you have any adnexal mass and a large amount of free fluid in these earlier studies, that constellation of findings also had a 100% positive predictive value. The other features that I've described, namely the presence of an adnexal hematoma, free fluid or fluid, a small amount of fluid in a mass, has, as you can see here, much lower positive predictive values for this diagnosis. But the key is that even when we put all of these features together, we're still only about 84 or 85% accurate in identifying ectopic pregnancies on endovaginal ultrasound. And so approximately 15% of the time, you have a patient that's pregnant, you have a patient who is symptomatic, and the endovaginal ultrasound is negative. And this happens so commonly that recently this has been given its own descriptive term, namely pregnancy of unknown location, or PUL as it is abbreviated. And what this is defined as a patient who is pregnant, who has a positive beta-HCG, but no evidence of either an intrauterine or ectopic pregnancy on endovaginal imaging, no evidence of retained products of conception on endovaginal imaging, the patient is hemodynamically stable, and there's no sign of hemoperitoneum on ultrasound. And in most labs, this happens commonly. In a recent gynecologic consensus conference, the incidence of this occurrence was estimated in different labs at about 8 to 31% of the time. And it depends basically on two factors. First of all, it depends on how early one is asked to image the patient, because if you're asked to image the patient at about 3 weeks gestational age, of course your sensitivity for finding either an intrauterine or extrauterine pregnancy will be much lower than it will be at a later gestational age. But it also depends on how well you do your examination. So clearly, in laboratories that have less experienced sonographers, the number will be higher than in a laboratory that does a very extensive, complete protocol with very experienced sonographers. Now, when this group looked at the ultimate outcome of these pregnancies of unknown location, they determined that most of these are either failing intrauterine pregnancies or ectopic pregnancies. But as many as a third of these pregnancies of unknown location, in fact, turn out to be early normal intrauterine pregnancies. So the question is, how do you manage these patients? And their recommendation is that what you need to do is to correlate with serial and follow-up beta-HCG levels. Again, to remind you that one of the criteria for making the diagnosis of the pregnancy of unknown location is that the patient is hemodynamically stable. So what they recommend is that if the patient is stable and there is no intrauterine pregnancy or ectopic pregnancy identified on the endovaginal and transabdominal exam, it is safe to watch the patient and repeat the beta-HCG in 48 hours. And when they repeat the beta-HCG, there are, of course, 3 possibilities. If the beta-HCG is increasing, and increasing at the expected rate, you are probably dealing with an intrauterine pregnancy, just a normal early intrauterine pregnancy. And again, they will watch that patient. If the beta-HCG plateaus, doesn't increase or drop, and they don't see an intrauterine pregnancy, then you are most likely dealing with an ectopic pregnancy. And if the beta-HCG is dropping, you are likely dealing with either an ectopic pregnancy or a failing intrauterine pregnancy. So in both of those scenarios, a beta-HCG that is plateauing or dropping, and on repeat ultrasound there's no evidence of intrauterine pregnancy, you're likely dealing with either an ectopic pregnancy or a failed intrauterine pregnancy. And in either clinical scenario, it would be safe to treat with methotrexate. Now, some of the people at the consensus conference were concerned about treating a patient with methotrexate without identifying a pregnancy, and so some people would actually recommend that laparoscopy and or DNC be performed in order to clearly identify trophoblastic tissue in order to exclude the possibility of a beta-HCG secreting germ cell tumor, but there was not ultimate consensus on that last thought.